you all so much for having me. It's great to get to meet so many folks through the Lung Cancer Initiative. As we mentioned previously, I'm very new to Chapel Hill. I just started here. I finished my fellowship at the University of Pennsylvania, where I had a particular interest in immunotherapy and was doing basic laboratory work with translational work and combination immunotherapy. So what I thought I would do today is provide a big picture overview of immunotherapy and lung cancer, and hopefully include some of the recent updates from the past couple of days, and talk specifically also about the mechanisms underlying how immunotherapy works, and hopefully where we're going to be able to go with this in the future. Just a brief outline, so I'll just touch briefly on where we started with lung cancer, the previously approved therapies, and then a little bit of a primer on tumor immunotherapy and what immune checkpoint blockade means. Go over what the current data is, and a little bit on biomarkers and the new interest in terms of combination therapies, and then briefly touch on some future directions. So, as you're all, I'm sure familiar, before the advent of immunotherapy and lung cancer, there were three main areas in terms of the treatment for patients with advanced disease, so stage 4 lung cancer. Chemotherapy was really the workhorse for the majority of patients. And there were targeted therapies that were available for patients that had specific molecular alterations, EGFR, ALK, and ROS1 mutations. And then there was some use of anti-angiogenic agents such as bevacizumab, along with chemotherapy. Some of the challenges with these therapies is that with chemotherapy, side effects were quite common for patients, and often there was a limited duration that these therapies would work. Resistance was pretty universal. Targeted therapies, while the side effect profiles tended to be better and more tolerable for patients, resistance tended to be very common as well, and this was also only available to a subset of patients that had these molecular alterations. So immunotherapy was really a novel approach, and has been quite different in how it works because the actual target of the medications is not the tumor cells themselves, but the immune systems, and I'll go into that a little bit more. Just a brief primer to start out on tumor immunology to set the framework for how the immune checkpoint blockade works. So the development of an anti-tumor immune response is a pretty complicated and multi-step process, and I won't go into all the details of that, but just to briefly touch on it, as cancer cells and other cells in the body acquire mutations, they can produce abnormal proteins or cancer cell antigens. And when these cancer cells undergo death, they can be recognized by immune cells in the body. There's these scavenger cells that are sort of the sentinels of the immune system, which then traffic to lymph nodes to then prime and activate T cells, which are really the effector, the functional arm of the immune system, and the target of a lot of the therapies that are now currently approved for patients. When these T cells get activated, they then have to traffic back from the lymph nodes through the bloodstream and back into the tumors to be able to ultimately kill the cancer cells. And as you can imagine, there's a number of different regulators of this process, both in the positive and the negative fashion. And that's been the focus of a lot of research in the immunotherapy realm, to see how we can manipulate this to improve our therapeutic options. So just to start out with, one of the basic factors of the immune system is that our immune system has to be able to recognize cancer as foreign. And because cancer derives from our own bodies, one of the mechanisms that was identified for this was that cancers acquire mutations in the DNA. And through those mutations, abnormal proteins get produced, which then generate what we call neoantigens, which are the basis for the body to recognize cancer as foreign. And one of the things that was recognized pretty early on, and is depicted in this graph, is that different types of cancers have different numbers of mutations and presumably different numbers of these neoantigens. And lung cancer, along with other cancers such as melanoma, falls on this side of the spectrum, where there are a frequent number of mutations or frequent numbers of these neoantigens. And since these are the substrates of how the body's immune system recognizes cancer as foreign, it was thought that these types of cancers might be more likely to respond to immunotherapies. And that has been clinically the case for cancers such as melanoma, were one of the first ones where immunotherapies were effective. Now, even once the body has recognized these abnormal immune cells and generated a T cell response, the cancers have derived a number of ways to negatively regulate those immune cells. So I'm showing here that in addition, after the T cells are generated, when they try to infiltrate these tumors, one of the defenses that's put up is that the T cells have on their surface these receptors which can negatively regulate their function. And you can imagine that in the course of a normal immune response, let's say to an infection, you would want those negative regulators to be there because you get the infection, your body's immune system clears it, and then you want that immune reaction to go away. You don't want it to be persistently active. But in the case of cancer, this might be an aberrant normal function, and that the cancers use this to actually be able to grow despite the presence of these T cells. So you have these inhibitory receptors on T cells, and when they get engaged by ligands such as PD-L1, which can be present in cancer cells or other immune cells in the tumors, this actually causes these T cells to go into a dysfunctional, or what we call exhausted state, where they can't clear the tumor cells anymore. And one of the really important observations that was made in the laboratory and then translated into patients in the clinic is that you can actually reverse that. It's not a permanent state of dysfunction, and when you block this interaction using antibodies to PD-1 and PD-L1, you can actually reinvigorate the T cells to then clear the tumors. So this was a pretty big advance in the field. So this is just an interesting little video showing how these T cells can infiltrate into tumors, which works. But in these images, you can see that the tumor cells are green and the T cells are red. And you can see the T cells sort of infiltrating within the tumor. Just as a visualization of how T cell treatments work differently than chemotherapy treatments. So what I thought I would start by reviewing is how these anti-PD-1 and PD-1 therapies were first introduced in lung cancer, which was in the second-line setting, so in patients after they had already been treated with chemotherapy. So this timeline illustrates really how rapidly this field has evolved. This was from a recent review by Roy Herbst at Yale, which shows that really for over a decade, there were main advances in lung cancer were with some of these targeted therapies. That really starting in 2012 with the first activity of Nivolumab, we've had really a dramatic change in the number of agents that are approved and also in the various lines of therapy for which they're approved. So I'll start out with summarizing some of the data in the second line setting. So this is survival data from patients with squamous lung cancer treated with Nivolumab compared to chemotherapy, docetaxel, which was the standard of care in the second line setting. And previously there was a thought that there might be differences in activity between squamous cancers versus non-squamous, and so they were subdivided. We've subsequently seen that it seems to be relatively similar, so those patients are grouped. But in this graph, you can see that in terms of overall survival, so how long patients live, those treated with Nivolumab live longer than chemotherapy. This was also borne out in patients with non-squamous lung cancers, so again, Nivolumab compared to docetaxel. And then when we realized that one of the things that was really different about immune therapy is that in contrast to chemotherapy, where the duration of those responses tended to be short-lived, what was exciting about immune therapy was the responses in the patients that did respond tended to be longer. And this is shown in this plot here, where you can see that the duration of the response for Nivolumab is longer than for Taxotere, docetaxel. Now, just to review the other two checkpoint antibodies that are also active in the second-line setting, Pembrolizumab, which is also an anti-PD-1 agent, was compared to docetaxel. You can see here, again, improvements in overall survival, and they tested two different doses. And this is in all non-small cell lung cancer patients. And similarly for atezolizumab in the second-line setting, atezolizumab is an anti-PD-L1 antibody. When you compare to chemotherapy, again, an improvement in overall survival. So all three of these are now approved in patients in the second-line setting. And just to briefly show some pictures of how the clinical responses can be seen, this is a CAT scan of a patient initially at baseline with the arrow here pointing to one of the lung lesions. You can see the regression of the tumor over time. And I wanted to make a point of a couple of important things in terms of the responses to immunotherapy when we're monitoring patients. One of the things that we noticed that was different is that oftentimes it can take longer for us to initially start to see responses to these therapies. So here, this is all at 6 weeks, and you can see just starting to see some shrinkage, but it's really over a longer course of time where you see resolutions of this in the imaging. Then I also just wanted to make a brief note on the question of pseudoprogression, because this does come up clinically when we're practicing quite often. And this is the concept that sometimes on a scan, the tumor might actually appear larger even after you start the therapy, but that there might be regression of the tumor down the road. And the concept is that because you're activating the immune response, maybe you're getting more immune cells that are infiltrating into your tumors and trying to clear those cancer cells so that the tumor actually appears larger, but then will continue to regress later. And this has been looked at because in melanoma, where these immune therapies were used more frequently earlier, this was something that was observed in patients. And it is something that can be seen in patients in lung cancer, but we've seen when we look back that it's usually not the norm. It's actually usually about 5% of cases where that's what they're seeing is pseudoprogression. So typically, if the tumor are getting bigger, that would represent progression of cancer. But it is something that we monitor closely as we're looking for responses in our patients. The other thing that was quite exciting about when we compared immune therapies to chemotherapies was this, which is a table just summarizing the differences in terms of adverse events in these patients. So here on the left, it's just from some of the early data from Nivolumab comparing the chemotherapy to Taxotere or docetaxel. What you can see is, just to summarize, not focusing on specific side effects, is that in general, the frequency of grade 3 or 4 or more severe side effects was lower in the patients that were getting immune therapy compared to those that were getting chemotherapy. And many of the common side effects that we associate with chemotherapy were not things that we would see with immune therapy. So things like nausea, anemias, other cytopenias, fever, neuropathy, those weren't the types of things we were seeing with immune therapy. And so people tended to be able to tolerate these treatments much better than the chemotherapies from prior. That isn't to say that there weren't other side effects that we do see with patients that are on immune therapy and that are really important in terms of monitoring and responding to. And one of the things that we do see is that in contrast to the types of side effects with chemotherapy, side effects with immune therapy are more from unwanted or inappropriate activation of the immune system against normal organs. So you can see inflammation in a variety of different organs, as shown in this picture here. Really, in pretty much any organ in the body, there's been reports now where you can see inflammation. The ones that are more common are things like colitis, so inflammation of the colon leading to diarrhea, or changes in terms of the function of the thyroid leading from thyroiditis. But there are a number of other organs that are involved, including the lungs, from pneumonitis, the kidneys, the liver, and even the skin. And we're still learning the potential side effects that we're seeing since these are newer therapies, and we're also learning on how to manage them. And the important points are that it's important to report symptoms. We do regular monitoring of laboratory function for patients, such as thyroid function, to kind of catch these things ahead of time, and that we can often manage them with steroids, and that it doesn't always necessitate a discontinuation of therapy. It's really on a case-by-case basis, depending on the severity of the symptoms and how quickly they can resolve with treatment. So the excitement from the second-line setting of immune therapies was pretty remarkable. But when you look a little bit closer at that data, what was a little bit concerning is that it really was only a subset of patients, even with immune therapies, that was responding. And really across various different studies, 20% was sort of a number that jumped out. And we wanted this therapy to be active for more patients. So as we think about ways to enhance response to immune checkpoint blockade, there's a couple of different strategies. One would be to select out patients that are more likely to respond, so to identify a biomarker that would enrich for the patients that are likely to respond. And this is important because while these therapies tend to be better tolerated, if we can select those patients that are more likely to respond, we can spare other patients potentially some side effects from the therapy. And biomarkers for PD-1 have been quite intensively studied from the outset. The biomarker that's been most extensively studied is the expression of that ligand for that receptor, the PD-L1 expression, either on tumor cells or immune cells. And this is the marker that is currently approved in terms of use for selecting patients for this therapy, and I'll go into that a little bit more. So this is an immunohistochemical test. This is just an examples of staining of tumor cells or both tumor and immune cells. And this is a test that there's a number of different antibodies that are currently being used, accompanying to the various different drugs that are on the market as well. And while these markers have tended to enrich for patients that are more likely to respond to the therapies, what's been complicated and difficult to interpret in a clinical setting is that there are a number of different assays, and there's been a lot of work recently in terms of harmonizing the results of those assays. But the decision is often not binary. So if you say at this cutoff, nobody's going to respond below this, or all the patients are going to respond above this, it's not really the case. The way we had seen it with targeted therapies, where EGFR mutations were really the only cases where we would really see meaningful responses to targeted therapies. It's not quite been the same case with immunotherapy. Other very promising markers that are continuing to be looked at include tumor mutation burden, so looking at the number of mutations in the tumor, which would be a surrogate for neoantigens. And this graph here shows some of the very early work in lung cancer, showing that there was a correlation between the number of mutations as well as the likelihood of the patient that was going to respond. So when they looked at the number of mutations in the tumor, the patients that had durable clinical responses on average had a higher number of mutations compared to the patients that did not have durable responses. But again, you can see the challenge is there's no specific cut point where you can say patients above this all are going to respond, or more likely to respond, or nobody below this cut point is going to respond. So again, a little bit of trickiness in terms of implementing this in the clinic. But there are also a number of other gene signatures and T-cell gene signatures that are being investigated by different groups. So using the available biomarkers, the PD-L1 expression on tumor cells, patients were selected for first-line therapy with pembrolizumab, which is one of the anti-PD-1 antibodies. So this is data from the KEYNOTE-024 study, which selected patients that had PD-L1 expression greater than 50% on their tumor cells. And as their first-line treatment, they were randomized to either pembrolizumab or standard doublet chemotherapy for lung cancer. As you can see here, there was a significant survival advantage in terms of progression-free survival for the patients that got immune therapy using this biomarker cutoff. And this is subsequently translated to an improvement in overall survival as well for those patients that got pembrolizumab in the first-line setting. And this led to the approval of pembrolizumab in the first-line setting in patients with non-small cell lung cancer. So biomarkers are one approach, but the other approach to expanding the number of patients that may benefit from immunotherapy would be to choose appropriate combinations to see if we can get complementary therapies that would work together. And this has been the focus of significant subsequent research. And when we looked at patients that weren't going to be responding to immunotherapies, one of the things we observed is that there's a group of patients that don't seem to have an immune response already there to their cancer. So their cancer's got an ability to hide from the immune system, so there just aren't T cells there. And so one thought is that how can we get the body to see that this cancer is foreign again? We want the shield to come down. And so there were a number of approaches that have been adopted, but the one that's gotten the most data to date is the use of chemotherapy in combination with immune checkpoint blockades. Here the idea being that chemotherapy, by killing some cancer cells, can release some of these abnormal proteins, generate some inflammation that causes your body to recognize the tumor as foreign. So to start with, in patients with non-squamous, non-small cell lung cancer, so adenocarcinomas predominantly, carboplatin and methotrexate were combined with pembrolizumab immunotherapy in the first-line setting. And I'm summarizing data here for overall survival in these patients. And what you can see from the graph is that in patients in which, in the first-line setting, pembrolizumab was added to their initial chemotherapy, there was a significant survival advantage compared to placebo alone. And so this led to the approval of this combination of treatment in patients in the first-line setting, and this was irrespective of that PD-L1 marker expression. And then this is just very recently presented data looking in patients with squamous cell lung cancer. So here again using a combination of standard chemotherapy, either carboplatin, paclitaxel, or nab-paclitaxel, combining pembrolizumab. they showed that there was, again, a survival advantage for the patients in the frontline setting, irrespective of PD-L1 expression, compared to receiving placebo alone. And this was just recently published in the New England Journal, but is also very exciting for patients. Now, there are also a number of other combinations that are being looked at, and so here I'm showing you the data from the Empower 150 study, which combined chemotherapy with bevacizumab, so an anti-angiogenic agent, plus PD-L1 blockade. And in the top graph, you can see that in the patients that got the combination of all 4 of those agents, there was an improvement in survival relative to just bevacizumab and chemotherapy arm. And what was particularly interesting about this trial, and we're still learning how to intercalate this therapy with the others, is that in comparison to the many of the other combination chemotherapy and immunotherapy trials, this trial included patients with EGFR and ALK mutations. And these patients were usually excluded from the other studies because we've seen that these immune therapies don't tend to work as well in patients that have these targetable mutations, presumably because they don't have as many mutations to be recognized by the immune system. But interestingly, these patients were included in this study, and they actually seem to derive benefit from the combination of all 4 agents relative to just chemo plus bevacizumab. And we'll see how that plays out with larger patient populations moving forward. So I've initially focused on the combinations of chemotherapy plus immune therapy. But we also recognize that while there's been a lot of interest and excitement about PD-1 as a target for immune checkpoint blockade, T cells have a number of different negative regulators, things that curb their normal function. And actually the first one that was targeted with immune therapy is the CTLA-4 antibody, which was approved in melanoma. And this is also another negative checkpoint that's present on immune cells. And so there was a thought that can we use this in combination to see if that can improve responses. So the lung cancer was initially combined with chemotherapy. And this is an older study where they added Nivolumab to patients with squamous cancer and saw that there actually wasn't an improvement in survival with the combination. But more recent studies have looked at the combination of the CTLA-4 blockade plus PD-1. And this is data from the Checkmate 227 study, where they took patients in the first-line setting and subsetting those that had a high tumor mutation burden, which they selected as those patients with greater than 10 mutations per megabase, and compared the combination of the 2 immune checkpoint blockades plus chemotherapy. And here they're showing data for progression-free survival. You can see that the patients that got the dual immune checkpoint did better than chemotherapy. And we're we're still deciding on how to use this data, because in this trial, it was compared to chemotherapy alone. We have other new data for combining chemotherapy plus immune checkpoint blockade in the first-line setting. So how to fit in this dual immune checkpoint blockade therapy in our current practice is something we're all working on still. But this is another approach to improving the response rates to immunotherapy. And more recently, what I focused initially was in stage 4 cancer, but more recently there's evidence that these immune therapies have roles in earlier stages of lung cancer. So the first area where it was looked at is in patients with stage 3 lung cancer that were treated with a combination of chemotherapy plus radiation together. And this stage 3 lung cancer hasn't had any changes in its therapy for quite some time. So it was an exciting change. So this is data from the Pacific trial, which was also just recently updated in the New England Journal yesterday, showing that after patients with stage 3 lung cancer had completed their concurrent chemoradiation therapy, they randomized patients to receive durvalumab, which is a PD-L1 antibody, or placebo, and that patients that received durvalumab had a dramatic improvement in terms of their progression-free survival compared to the patients that received the placebo. And this was updated in terms of overall survival as well, so that patients that had received durvalumab had an improvement in their overall survival compared to placebo. So this led to the approval of durvalumab for patients with stage 3 lung cancer after they had undergone their chemoradiation. Patients got the durvalumab for a year after the therapy. So we can see that, well, the initial use of these agents was in the stage 4 setting, that these agents might be more applicable in earlier stages as well. And there are ongoing trials where they're being tested in the adjuvant setting for earlier stages of cancer as well as in the adjuvant setting after surgical resection. So to summarize where we're at in terms of treatments with immune therapies to date in the stage 4 setting, which is where they're predominantly used currently, in the first line setting, in patients that have a PD-L1 expression greater than 50%, pembrolizumab has been approved. And then also for PD-L1 unselected patients, carboplatin, pemetrexed plus pembrolizumab is approved in patients with non-squamous non-small cell lung cancer. And there is recent evidence that there is an improvement also with chemotherapy. In the second line setting, the indications for what's approved include in unselected patients, both nivolumab and atezolizumab are approved, and then for patients with PD-L1 expression greater than 1%, pembrolizumab is an option. And while I didn't spend too much time on it today because I think we're still earlier on in terms of small cell lung cancer, I did also want to mention that nivolumab has been approved in the third line setting for these patients. And very recently, actually again in the New England yesterday, there was data for chemotherapy plus atezolizumab in the frontline setting for patients with extensive stage small cell lung cancer, showing a benefit to that combination as well. So the exciting changes in the small cell world as well, I think. So just to briefly summarize also, the currently approved agents in the lung cancer world for immune therapies are targeting PD-1, but there are other immune checkpoint blockades that are being investigated targeting CTLA-4. We also have approval for a PD-1 agent in the stage 3 setting for lung cancer. And there are a number of other combinations that have shown promising activity that we're still deciding on how exactly they fit in terms of our treatment regimens. And hopefully with more data we can have information for patients to decide on some of those treatments as well. So all of this change is quite exciting, and it gives us many more options for treating patients, but there's still a common issue of resistance, both primary resistance for patients that don't respond initially to these combination therapies, and then secondary resistance, which develops after patients are on therapies for a while. And it's been challenging to learn exactly what those mechanisms of resistance are in the immunotherapy world. And that's partially just because of the challenges of studying the immune system in patients. It's harder to identify specific biomarkers of resistance and know how to target those. And those are important studies that are ongoing. The other challenging part is that while we've had drugs targeting PD-1 and CTLA-4, we know that there are a number of other negative regulators of the T-cell response. Just as examples here, TIM3, LAG3 ligands, there are a number of different agents that are under investigation targeting these currently. And then there are other negative regulatory factors, other immune cells that can curb the immune response, like regulatory T-cells, myeloid cells, and there are agents targeting these as well. And this all has led to thousands of trials of combinations of immune therapies to try to get at different mechanisms of resistance that the immune system has developed to the cancer. But the challenge is how do we best decide on the combination for a given patient? And that's what we've been struggling with as we see people in the clinic. And this is where there's a significant need for research, both in terms of biomarkers and clinical translational research, but also in the basic science realm of which of these factors are going to be most important to decide on the therapy that's usable in a particular patient. So I will end there and take any questions.